So a couple of announcements before we move on to this wonderful topic and presentation. We closed the elections for the co-chair and secretary positions. So we will have now a window for you guys to vote. And the window is opening December 7th until December 21st. You will see in the listserv an email going out announcing that the vote period is open. And then we will announce the positions in the January SIG meeting. So having said that, this is my last co-chair meeting. So I want to thank everyone, the senior leadership, some of you here today, for your help, helping me become the co-chair and do this work with the current team. And then, of course, my current team, Rachel, Amelia, Jonathan, and Michelle. It was wonderful to work with you, and I will continue to come to the SIG meetings, obviously, and doing anything that I can do to help grow this and create this space that is a safe and welcoming space for everyone to discuss any integrated care issue for pediatrics. So yeah, that's my goodbye, and we can now move on to the topic.
Well, I do just want to jump into and on behalf of everyone here and the SIG, just thank you for your service and your contributions these past 2 years. You've been such a great advocate for the SIG. You've done a lot of work in increasing visibility on the listserv. You've worked with several other SIGs. And you work really hard behind the scenes to make sure everything runs smoothly. So I really appreciated everything that you've done. I've learned a lot from you. So we're going to miss you, but we're glad to hear that you you're going to be coming back. You're still a part. So thanks again for everything that you've done. So I think that's it in terms of announcements, correct? So what we were going to do, we're going to start with Jonathan to kind of get us started on our topic on perinatal mental health. And then we are going to have our speaker, Brenda, jump in here in a little bit, and I'll introduce her after Jonathan does the research corner.
Hi, everyone. Hope you're all doing well today. Sorry, I just got back from a meeting real quick. Share my screen. All right, and thank you to Brenda for recommending these resources. I had a chance to review them, and I'll just briefly touch on them so everyone can be kind of caught up to speed. So these two articles, one is current recommendations for screening and management of postpartum depression, and the other screening fathers for postpartum depression. So the first one, it basically provided recommendations that pregnant mothers should be screened for depression at least once during the perinatal period, and again at the postpartum visit. It also suggested potentially screening new mothers at infant well visits, 1 month, 2 month, 4 month, and 6 month well visits. As far as screening tools, the EPDS is quite common. A 10-item scale takes less than 5 minutes to complete. It's appropriate for patients with low health literacy. It's been translated into over 50 languages. It also assesses anxiety. Also, the BDI that we know is often used. It's a 21-item scale, takes about 10 minutes. However, the article suggests that the BDI may kind of capture some symptoms that are normal during pregnancy or the postpartum period, like sleeping difficulty. The article also provides these resources, provider and patient resources. I'll let you guys read that, or this will be sent out. As far as treatment for postpartum depression, the non-pharmacological treatment includes psychotherapy, particularly for patients who don't want to expose their newborns to medication. Also, physical activity during pregnancy. As far as pharmacological treatment, SSRIs, SNRIs, and they can obviously be used in conjunction with psychotherapy. The article recommends that patients and healthcare providers can meet with and talk about the pros and cons of using medication. The article also says that the research has been limited or has noted minimal impact on infants, few adverse effects. As far as prevention, early identification and treatment, screening for antepartum depression, antenatal counseling, especially for those at risk. And so what are the implications here? To really establish protocols and screening measures, patients should be counseled during their pregnancy regarding symptoms and signs of postpartum depression. Patients identified with risk factors may need to be screened more frequently, along with preventative interventions. And really that providers should establish protocols for treatment, referrals, and follow-up for continuity of care. Jumping to the next article, screening fathers for postpartum depression in a maternal child health clinic, a program evaluation in Midwest Urban Academic Medical Center. I found this really interesting. So postpartum depression impacts fathers as well as mothers. 8 to 13% of fathers meet criteria, and up to 50% when the mother is experiencing PDD. Paternal PDD is a risk factor for worsened quality of life, poor physical and mental health, and developmental and relational harms in the father, mother, child triad. Currently, there are no recommendations for postpartum depression screening among fathers. As far as the method, this was a pilot study conducted in an intergenerational postpartum primary care clinic located within an academic medical center. Fathers who were actively involved in relationships with mothers or infants receiving primary care in the clinic were approached with mother's permission. Mental health history, current stress levels, and the EPDS was collected. As for results, 24 fathers completed the screening, 83% participated that were asked. The mean age was 31. 87% of the fathers identified as belonging to racial or ethnic minority groups. Fathers reported low rates of stress and pre-existing mental health conditions, but 30% screened positive for postpartum depression on the measure. There was a qualitative section, and the interviews revealed that fathers acknowledged significant stress, anxiety, and depression, but were often resistant to receiving direct support. And they also suggest gaps in healthcare. 26% of fathers were uninsured. 54% did not have a primary care provider. And after being screened, 2 of the participants requested mental health services, and 3 established new primary care with a physician. So what does this all mean? That, well, first, participation in being screened for PVD was high among fathers, most did. And 30% of fathers screened positive, much higher than the expected rate from 8 to 13%. And so basically engaging in this screening was an effective tool, and it provided further resources for these fathers. And the biggest recommendation is just basically bring this into routine practice in primary care to reach more effective fathers to support the health of families. All right, and that's that. Thank you.
Awesome. Thanks, Jonathan. I think you set the foundation for the topic, and I'm really intrigued about the assessing fathers for postpartum depression. So hopefully we can have a little more discussion about that. So without further ado, I'd like to introduce Dr. Brenda Papiernak. She is from Ascension St. Alexis Women and Children's Hospital, and she is going to talk about perinatal mental health screening and referrals.
You can see my screen?
Yes.
Awesome. Okay. So I definitely did kind of, I'm going to keep my language. Obviously, most of the research is related to women, but we are seeing a push in our recommendations starting to come out that we really should be looking at the full family dyad. So however that looks, that's what we should be looking at. So I think if we start having the language around it, it'll be helpful. Trying to fix my thing so I can see what okay. So my goal is to kind of help. I'm actually not going to talk too much about symptoms. We're just not going to have enough time, but there'll be little pieces in there. But understanding basic screening and scoring, having some language, I think that is key. I think obviously it's complicated with screening in our pediatric setting. So, but I'm going to talk a little bit about why that's important. I'm excited because I do see some other PMHCs on there. So if there are people that have thoughts when we're going through this, go ahead and jump in too. So 15 to 20% of women can experience postpartum depression or anxiety symptoms. There has been a lot of research and newer numbers coming out about the maternal morbidity and mortality rates. 40% of postpartum deaths are related to mental illness or substance abuse concerns, which means that 40% of postpartum deaths are treatable or preventable is really what I'm trying to say. So mom's wellness is important for her and for her family. Without treatment, postpartum depression and anxiety can last for years, and it can affect mom's health. It can affect her children's health, her significant other's health. So it can impact the entire family system. But part of the reason I love what I do is that, and I tell families this all the time, perinatal mood and anxiety disorders are treatable. It doesn't have to be something that moms just kind of power through and try to get through on their own. As providers working in pediatric settings, our job is to reduce the stigma around the disorder by asking and supporting and referring to trained professionals. I think knowledge is power for our families. So for dads, the research is kind of in a few different spaces, but that article does talk about the 18 to 13% of new dads. In general, we kind of think our numbers for moms and dads are actually probably a bit higher. We're just not getting a full sense of reporting. Dads are at highest risk at 3 to 6 months postpartum. Moms, it can be during pregnancy or postpartum. And risk factors can be within the first 6. I mean, it could be anywhere through that time. I think our DSM says one thing, but we see a range of when we can see that diagnosis kind of start kicking in for mom during pregnancy or postpartum. As was recommended as was discussed in the articles, there are recommendations for universal screenings, both in the OB setting, but also the pediatric treatment settings. I'm going to get through some of this. And so as was mentioned also in that article and in a few different places, the American Academy of Pediatrics recommends screening for moms at 1, 2, 4, and 6 month well child visits. Despite that, less than 50% of mothers are screened nationally. It is very complicated. Not all states mandate for screening. Actually, very few mandate it at all. I'm in Illinois, and there is a mandate and laws on the book for screening both during pregnancy and postpartum. But often in pediatric settings in particular, parents are seen as separate from their infants, that we're supposed to focus on the screening of just the children. And there's worry about what do we do with those screenings? How do we chart that? How do we bill for that? So it is very complicated. I'm hoping this is going to work. So the Policy Center for Maternal Mental Health has done actually, it was very cool. In 2020, they put together a whole report card across the country of how we're doing with managing maternal mental health. And there's only one state that managed to get a C+, which was California. There were a few states, I think 6 of us, Illinois happened to be one of them, where there's a C or above. Oh, I'm sorry, California had a B-, sorry. The green are C's, and then everybody else is D's and F's. They looked at, are we screening? Are we, do we have resources and supports? Are we providing psychoeducation? Are we, do we have therapy programs like PHPs and IOPs for our moms? So there's just a lot of things that they looked at, and we're woefully behind a lot of other countries where, you know, there are regular screenings, regular supports, regular resources, regular check-ins with moms and dads after delivery. So we are, I have to figure out how to get back to my presentation. Let me see. Okay, let's see. There we go. I got back. Okay, so as you can see, it's complicated, but the 2020mom.org, you can look at that a little bit further and see where your state is at with that. And I think it's a great place for us to all be advocating and trying to better understand how do we support families. Let's see. Okay, so a few things. Parents don't always love to do the screenings, or will be hesitant to share regarding how they're feeling. So that is something that we have to understand as caregivers and providers. Many times they don't understand why it would be important for us to assess for that. They have a lot of fear over DCFS reports, fear of judgment. Sometimes they don't even understand, because of their own cultural and religious upbringing, what depression and anxiety might look like, and why it's important to talk about that because of how they were raised, or, you know, the discussions that happen within their own cultural context. So it's very important to have an understanding of that. I think it's important to explain to families and to sit and not just give them a form. I think that's often what happens, is that they'll be like, hey, here's some forms, fill them out, give them back when you're done. I think that's where some of the underreporting and low scores come in, that we don't have a full sense of how parents are doing, because they just will score all the zeros and make sure that their scores look great. And they get used to taking this screen, at least in our state, because they do see it so frequently. And so trying to talk to them about why it's important, and why it's important to be honest, but also normalizing and providing some psychoed even before they take the screen, about the percentages of families who can experience perinatal depression and anxiety, and that it's treatable, and that moms don't have to suffer alone, and that there's no shame in it. It is something that we have resources and supports for. So I think sometimes just normalizing that alone can help take away some of that fear of taking a screen and doing the screener. There's also a lot of debate over who should be doing it. In medicine in general, there's that silo mentality of behavioral health lives over here, medicine lives over here, let's keep them separate. And the reality is that, you know, we can't separate them. When mom's doing well, the babies do well. If dad's doing well, the babies and the moms do well, and everybody does well if we're all feeling good. So I think, you know, the questions of who's the patient, who's paying, is insurance gonna pay for it or allow for it? Where do we refer if mom scores high? We hear that a lot in our system, where doctors are like, well, I want to screen, but if a mom scores high, I don't want to be responsible for that. And which is not a great way to do that. But also I understand that it's difficult for providers to know what the resources are, to have time to provide those resources, and the worry about follow-up, because that is a thing that we have to look at. So, screening for families in NICU, PICU, other higher levels of care. And those families are going to be, mom and dad are at higher risk if baby was in the NICU or has follow-up medical concerns in the pediatric or PICUs. So we should be assessing for those if we've had a little one who has been in the hospital or was in the hospital longer term. That's an even more important reason to be assessing. So a lot of people think it's the OB's job. That's mom's treatment provider. But the reality is that the OBs see mom during pregnancy and at birth, and hopefully again at 6 to 8 weeks postpartum. Many don't follow up like they should. And moms don't reach out. They're not going to reach out unless they feel comfortable with that relationship. The pediatricians are the ones who see moms more often in that first year after delivery, and ongoing after that first year for even future children. So many times they have a long-term relationship with that family and have an understanding of some of the baselines or some of the concerns that can kind of come up for a family. So having some standardized screenings and referral algorithms can be helpful in a pediatric setting, and trying to put some things in place can be important for our families that we see. Even in my hospital system, I work in the NICU and our follow-up clinics and our pediatric clinics and such, and there's a little bit of that worry about mom's not the patient. What do we do with that? What do we put in the chart if mom screens high and we decide to refer? What do we do if mom isn't doing well? So I think that is something that a discussion to be had, but we shouldn't avoid it because of that fear of what do we do? So supporting families in general, pediatric providers, they're able to recognize, screen, and address those concerns because they see the families. Family involvement in pediatric care is linked to positive health outcomes for children, and the children are part of a family, and it's all interconnected. And the primary care providers have the ability to focus longer term sometimes on families' overall health. And this allows for better health outcomes for their pediatric patients as well when mom and dad are doing well. I'm going to talk a little bit about the EPDS, the Edinburgh Postnatal Depression Scale. It's the most commonly used screening tool for women during pregnancy and postpartum. And it can be used up to 12 months postpartum for both the birthing and non-birthing parents. And so that could be for dad, that could be as well for adoptive parents. It can consist of 10 questions, and we're looking at the previous 7 days. So that is another thing that should be discussed when giving this to the screen to families, is that it is not lifetime. Sometimes we'll have families that score high, and it's because somebody didn't kind of note with the family. We're looking at the last 7 days. How have you been doing for the last week? If there's concerns that are bigger than the last 7 days, obviously, having a family that feels comfortable opening up about that is important, but the screen is going to be looking at the last 7 days. The highest score possible is a 30. Recommended cutoff, I've seen a few different numbers over the years, but 11 tend to be pretty common numbers as far as, if a mom's scoring 10 or 11, let's go ahead and get her in and look at, possible mild depression, anxiety symptoms. As you can see with the scoring, it goes all the way up to severe depression with 19 to 30 in that range. I would say, though, I have had families where I've had a mom who has scored 0 and I've been incredibly concerned about her. I've had a mom who scored 30 and she's doing okay. And, needs some resources, needs some stuff, but it's not like she needs to be in the hospital because she scores a 30. So I think there's also a sense of like, oh, she scored a 0. Let's go ahead and put it away and we're done. It is a screening. It's meant to be a part of a discussion. And just because mom scores 0, if there's a sense or something that a provider is concerned with, we really should be asking more questions and kind of trying to get a sense of like, hey, how are things going? I did put a link here for Make PAP for Moms has a whole document with the different translations that they have. And about 18 of theirs is their validated translations. Another 18 are non-validated translations. And so it's kind of interesting to, one, have that available for patients who might need other languages, but also to have an understanding of which ones are validated, which ones aren't. It talks about all the research in that link. So obviously the PHQ-9 is a common tool that is used as well. And the Edinburgh Postnatal Depression Scale is, they look at sometimes different questions, but sometimes you can get the same information based on that. Questions 4 and 5 are important in the EPDS because it does look at the anxiety piece. It's almost its own little anxiety scale within that. So if mom is scoring high on those questions, it's important to have an awareness of that. So I'm just going to mention a few others. We're not going to go through much with that, but the PHQ-2 from the PHQ-9 is options for screening. The PASS is a perinatal anxiety screening scale. I've not used it partly because it is 31 questions, and I really would rather spend time talking with mom and getting a sense of things verbally versus trying to assess using a screener. The Edinburgh, the GAD-2, the GAD-7 can be used for anxiety. Obviously, the Beck Depression Inventory can be used as well for depression. The Perceived Prenatal Maternal Stress Scale is another option for understanding stress and depression states for pregnant women. PTSD, Primary Care PTSD Scale. That is a VA screen for PTSD. We do see a lot of PTSD with our families. So that is something to really be aware of. Obviously, our mood disorders and bipolar are something to be very aware of. Substance abuse screenings, suicidal ideation screenings, and just in general, our birth equity and social determinants of health are going to be important because we are going to see higher rates of depression, anxiety when there's concerns with our social determinants of health. So hopefully your offices are starting, if they don't already have them there, to be doing some of those screenings. Okay. So once screened, then what do we do? A negative screen still requires checking with the family. And sometimes that 0 is not really a 0. A positive screen indicates further assessment and just kind of checking in with the family and seeing what that means and what, what that looks like. And getting a family connected with a mental health clinician who's trained in perinatal mood and anxiety disorders is going to be very important because it can be a little bit more complicated understanding the hormonal and sleep and the stressors of being pregnant or postpartum. Those things can be very helpful to have further treatment in. Following up with moms are really good at avoiding their own care. So they will take care of their littles and family, but they don't always follow up. So that sometimes does require us to check in a couple of times. Be like, how's it going? Have you been able to follow up? What do you need if you haven't been able to follow up to help make that a little bit easier? Because sometimes they're scared. Sometimes they're worried about it. Sometimes they're worried, is it going to be covered? Is there options? I don't have time. I don't have a car. So trying to make sure that we understand what is going to keep them from doing treatment and what we can do to help them be more successful will be important. If a mom scores high, providing psychoeducation, even before they take the screen, like I said, can be very helpful. Discussing the difference between baby blues and a PMAD, and discussing the signs and symptoms of depression and anxiety, talking about self-care. Sleep is so important, and one of the biggest issues that happens for moms. which then can start that spiral with anxiety and depression symptoms. Talking about using supports, talking about finding ways to work through feeling overwhelmed, talking about those coping skills. Intrusive thoughts. I just want to briefly mention that because sometimes we will see that maybe mom scores something on question 10 is a suicide self-harm question. And just because a mom scores something on that doesn't mean we need to run right to, oh my gosh, she probably is going to kill herself. She's going to go in the hospital or needs to be in the hospital. We need to worry about that. Sometimes it does mean she has plans and intent. Sometimes it's just intrusive thoughts. There are a lot of intrusive thoughts that come up with our moms with anxiety in particular during pregnancy and postpartum. And those thoughts about not wanting to be here, wanting to disappear, wanting to maybe just go to sleep and not wake up are not the same as I'm thinking I'm going to kill myself. I'm going to take some pills and I'm just not going to be here anymore. So having a discussion around it, intrusive thoughts can be very anxiety based. And so talking with mom about that just because you share that doesn't mean that I'm concerned that you need to be in the hospital. Let's talk more about it and understand what resources would be the most helpful. I have a mom that I worked with who, a young mom in the NICU, and she'd been having intrusive thoughts about self-harm and not wanting to be here since she was 9 years old, and she's in her mid-20s. That's a long time to be having those thoughts. But if we had just gone based on the 3 that she scored on her EPDS, there was a lot of staff who were up in arms about that and very anxious, and having lots of discussions with her. She had no plan or intent. She had a lot of thoughts. So we talked about that and worked on kind of discussing what that meant and how do we work through those. And she had never done therapy really with that or talked about them. So it was that alone helped calm the thoughts, being able to talk about them and understand them. So treatment options, obviously individual group therapies can be helpful. Medications for many of our moms can be very useful if they are on medications during pregnancy. Sometimes the worst things our OBs or psychiatrists can do is to cold turkey take mom off all the medications. That can actually start triggering a lot of other concerns. It's a balancing act. Obviously, we want what is best for our babies, but sometimes mom treated in managing her bipolar, depression, anxiety is going to be just as important as mom not taking those medications. As was mentioned in the article with breastfeeding in particular, there are safe medications that can be used. And so talking to lactation is going to be really important, especially if mom's worried about that. So there's a few different options for treatment. I put in there some just information on places for families or providers to look for looking at medications. There are some great support options for moms and dads. Postpartum Support International is an amazing organization that has a warm line, has free online support groups. They have all kinds of different support groups, NICU, chronic illness, single families, South Asian mom support group. I mean, they have a lot of different things. So helping families find that can be very helpful for them to talk with other families who are going through similar experiences. There is obviously the National Suicide Prevention Hotline. There's a newer National Maternal Mental Health Hotline that has been put together both with HRSA and with Postpartum Support International, and it is staffed by therapists and clinicians who are all trained in perinatal mental health and who are able to kind of work through and support families in need. It's a great free resource for families. So having this hung up around your pediatric offices could be very helpful, or giving them to families if there's concerns. I put together a few different resources that you guys can click on, different links that just I find interesting or helpful. That is that. That's it. So I'm going to stop sharing my screen. I think that's it.
Wonderful. Thank you, Brenda. Such an important topic, such a great presentation. So we're going to open up to questions, and it looks like we actually already have some questions in the chat from Dave in terms of when do moms see primary care? How do you do a check-in with a family? We'll let you start there, and then we'll open it up to others.
So many times mom will use her OB as her primary care for many years during her her years that she's fertile or planning on having children, but even sometimes after that, her OB kind of can be her person that she goes to for long term. So PCP sometimes is their primary, and honestly, Medicaid, their insurance really can dictate sometimes who they're seeing. And so, you know, I think obviously if we do have a concern for mom with her, you know, she scores high on that APDS, or we're concerned about depression, anxiety symptoms, encouraging them to see their PCP or their OB is going to be very important because they can get in for support with them as well. I, as a health psychologist, am always very interested in wanting to make sure that, you know, when was the last time you've had blood work, or you've had, you know, just kind of checked in with your primary care just to make sure all that looks good, because pregnancy and the hormones and everything that kind of happens to our bodies during that time can cause some its own issues. So we want to definitely rule out any medical concerns. But then, you know, from there, we can provide resources, their PCP, their OB can provide resources. Yeah. So I hope that answered the question.
I had a question. I'm Matthew. I'm working as a behavioral health consultant in a pediatric primary care clinic, and we've been using the Edinburgh for years, and you know, having behavioral health consultants come in when the screener is elevated. And we bill for the screener, but we haven't figured out a way for our system to bill for the BHC component of the visit, the psychotherapy codes that might be associated with the visit. So I just wanted to throw it out to you and the group to see if how other folks have handled that, because we've been told that if we wanted to do that, we'd have to open the mom up as a whole patient within our system. And we're a pediatric clinic, so it doesn't make a lot of sense, I think, for us to do that. And wondering what other folks have done related to that. I know some places in Colorado, I used to work at Denver Health, where they would bill that first visit under the patient's name. But just wondering kind of if people are billing for those visits, what codes they're using, and how to make this work practically so it can be sustained.
I know for us, we will use the health and behavior codes and try to use that, because we are addressing the full family need, and which then is addressing any pediatric needs as well. But yes, obviously under that, we're not going to put mom's mental health history in a note in the baby's chart. So for us anyways, if there is that identified need, we are going to refer mom out, and, you know, we aren't doing a lot of billing with that, just more of the screening. So others might have more of might be able to talk more to that though.
Yeah, we've written the note. We write the note in the baby's chart, but encrypt it in a certain way that it's not released. But just the billing for the therapeutic part of the visit, apart from the PCP visit, I think has been more of a challenge.
Yeah, I think using the H&B codes, where it's the one, and I don't have it in my head right offhand, the with patient present is going to be at least what we use most often. So,
and you build it under the baby's name.
Yeah. Mm-hmm. Yep. At least that's what we're doing up at our NICU and such. So. Yeah.
Yeah, it's great. It looks like Carly was asking a very similar question as well, related to documentation. It looks like Dr. Smith has a question. Your hand is up.
I was just going to say that in regards to billing, sometimes the way that I conceptualize talking to the parent, if it's, for example, how to respond to the baby's behavior, and you're trying to do, you're really doing some like parent consultation. I can even see, in addition to using the HB codes, using the psychotherapy codes with or without the patient present, depending on the kind of intervention and what you're actually talking about. You could probably make a case for that too. But
so would you provide a diagnosis then? Would you in the chart? Well, if you're using the psychotherapy codes?
For the baby, I don't know. I'm thinking about a little bit older kids, like even like a toddler.
There is a code related to like child affected by maternal depression, but I don't think it's like an F code. But I don't know if that would be reimbursable, but.
Yeah, I'll just add, so I work in a primary care preventive, so 0 to 3 age group in Healthy Steps, and we have done lots of advocacy in states, and so some states you can use a Z code now to bill this, and like in Massachusetts, where CHUSIS also, positive maternal depression screen is a approved benefit, so that's one way to do it, but also being able to use, so some states also have DC 0 to 5 approved code. So there's a, maternal child health or relational health Z code that lots of states are able to use now too, if they have a crosswalk with DC 0 to 5 to the DSM.
I had another question though. I wonder, sometimes I feel like when you're giving like all of these options to a mom, that they can feel overwhelmed. I wonder if you found like a secret sauce for trying to actually get them to implement something that you're recommending. Like, do you have a certain approach or way that you try to make a plan, sort of?
Yes, absolutely. And I think it can be complicated by a lot of factors. If they are a single mom and they have limited resources, that's going to look one way compared to somebody who is going to have more resources, right? So I think having I very much work from a Maslow's hierarchy of needs space with many of my families, and sleep and eating and some of those basic self-care things are honestly where I'm going to start with so many of my families. I think I'm sure there's a few of us that have been moms of littles before, and I know that especially those first early few months, that can be the hardest thing, just getting some sleep and getting a nap in, or making sure that you're eating and drinking enough fluids. So starting there, and because that is something that can help our moods, right? If we are getting some of our adequate sleep, that can help alone with some of that basic mood management. I think breaking down in understanding what the barriers are, I think is going to be, and just kind of having a sense of like, okay, let's look at what you have for support. What do you have for resources do you have a computer? Do you have a cell phone where you can call into the mom's line? We have a mom's line in Illinois that we can provide, or the PSI line. Do you have access to utilize Zoom so that you could do a support group? Because sometimes those feel a little less scary than helping them get right to therapy. Understanding the cultural implications, I think, is huge, because some families are like, yeah, I do mental health discussions all the time in my family. And some are like, oh, no, we don't. No, we don't do that. So I think understanding context is going to be really important, and that's going to help guide you in how to encourage treatment and getting the support they need. And then, you know, asking what would be the most helpful for them. You know, what do they think would be? Because obviously we can only do so much in our limited roles. So what do they already do well, and trying to also help them notice those pieces too. I hope that answered your question somewhat.
I would be curious. Oh, go ahead, Jude.
No, go.
No, it's kind of related to Amelia's comment, and I was just kind of thinking a little bit about those who maybe have access. And I don't know if you're doing this, Brenda, in your setting. Some people might be doing brief intervention. So it looks like, Amelia, you're in a family medicine clinic, and you might be able to, the parent might be a patient as well. So I was just kind of curious, people who might be able to intervene more directly in their setting and what they're doing.
Yeah, I work in a pediatric setting, but we have a family med clinic that's part of our like organization. And so we screen all of our parents. And if an elevated EDPS comes up, we will create that chart if they aren't already a patient within our system to see them, and do our documenting there. But we treat the parent, unless it really is just focused on the kid, like they're having a hard time with like breastfeeding, or they're just like really anxious there. But if it really truly is like the parent is struggling with anxiety or depression or stress or whatever it is, and it really is parent focused, then we'll create a full chart. But if it is just like, I don't know how to deal with, how do I feed, my baby's crying at night, like what do I do, then it's very much under the kid's chart. But if it's really about the parent and their mental health needs, then we create a chart for the parent.
Nice.
I just wanted to ask a question about the SWIG. Who in the call uses that? Because when Matthew asked his question, it came to mind that for us, we use the SWIG, and those are the pediatricians utilizing the screener that is embedded in the SWIG. So it's not, I don't know how it gets billed, but it's billed by the pediatrician. It's not billed by the behavioral health team. So I don't know if others are using the SWIG or not. And Amelia, is the SWIG version you use also the one that incorporates the Edinburgh into the, I think it's 2, 4, and 6 months.
Yeah, it is. So we'll use that one, and that's one of the pathways that we'll get like a warm handoff to behavioral health. If any of those come up flagged, the MA just automatically goes, hey, this patient's probably going to need to talk to you. The pediatrician will have a chat, and then most of the time they're like, oh yes, we're going to have you chat with behavioral health.
And I would say, honestly, what is really hard, even in just this discussion, like how do you bill, how do you chart, all that, honestly, it's all so state dependent. I mean, and what the Medicaid providers are allowing or not allowing, or it definitely is so complicated. It shouldn't be that complicated, but it is.
Two other thoughts I was just going to throw out. One is just the idea on the SWIC or any other social emotional screen, that sort of how to go from that direction, right? Where there's a concern about feeding or sleeping or caregiver's ability to soothe the baby, whether that then leads back to a screen for postpartum. And so one is just, you know, how are people lifting that up and being mindful, and is that a part of a standard protocol, that if there's an elevation on a social emotional screen, that it's an indicator that we consider caregiver depression and anxiety. But then also the other piece I was thinking about too is just what, you know, part of what we've been talking about is, you know, treatment for caregivers and what they might need, but then also what else might we be doing in service of the dyad, just to keep, I don't know what other people are doing, if that's a concern, and sort of we're, you know, maybe referring out or trying to connect mom or dad with whatever they might need, but also then how can we then also mitigate risk and buffer and build, you know, resiliency in the developing child as well. So just throwing those two things out there for thought.
I know in some of the work I do, because I see patients in a few different realms. So, but in my NICU setting and our NICU follow-up clinic, doing a lot of attachment-based work is really key for a lot of our families, because they're, as you mentioned, like if we're seeing that attachment not quite happening, is it related to mom's mental health concerns? You know, is baby's fussiness related to her anxiety, right? You know, so sometimes if we get mom's anxiety understood, baby calms down miraculously. So it just, yes, I think having an awareness of that is important. But again, the psychoed and trying to dispel some of the myths of like, you know, if we didn't have that immediate connection with baby, that means we're not attached to our baby, right? If for some reason angels weren't singing and there were rainbows and birds and everything when we first met our baby, like then we're not attached. And I trying to talk families through that and that understanding of what attachment is. It's so much more than just our feeling of attachment and love. It's taking care of our baby and taking our baby to the doctor and being aware of baby's colds and being aware if baby's too hot or too cold and feeding baby and checking it. And so like, it's much more complicated than just this idea of what love is. So trying to provide that psychoed, again, I think that can provide a buffer and some support, and then also helping them find resources to get more support is how I kind of will do it.
Brenda, is there any specific curriculum you use for these visits that is available to all that you can share?
Specific, say it again.
A specific curriculum that you use for the visits, like that include flyers and things for the parents to destigmatize or
Yeah.
identify. Yeah.
You know, if I was really organized, I would have like a really amazing cookbook of all my stuff. I have not yet done that. It's all in my head. And then I'm like, oh, let me find this resource for you. And so a few things. One that is actually, it's a Chicago-based organization, but it's a great one that I didn't include in there is Fussy Baby Network. I know that it's Illinois-based, but it does have some ability to support outside of Illinois. You can just Google Fussy Baby, and that is a really good resource. And they do a lot of 0 to 3 work, but can help support families if they're having a hard time with that fussy baby or not feeling attached. And we'll look at that. So that is, with regards to that, that's an organization I do, as well as, like I mentioned, Postpartum Support International and, you know, some of the different, I think it just, obviously each family brings in their own needs. So I guess I'm just always mindful of that. Yes, the Erickson Institute. Yep. That's a great one.
As a kind of follow-up to that, I think I noticed that you did have a perinatal mental health certificate. Is that kind of what?
Yeah.
Tell us a little more about that training.
Yeah, so Postpartum Support International, I want to say it was in 2018, began having a perinatal mental health training that then allowed to go towards the certification. And it's it's 2 different levels of training that kind of helps you have that more intensive understanding of working with a perinatal mental health patients. And then the certification kind of just helps you, one, stay up on top of all the newest trainings and research and such, but kind of helps patients and insurers know that you've had that extra training. So going through Postpartum Support International is where you can get that information. The initial exam is a little expensive, but what I would say about that is it's not an exam that you just have to kind of submit that you've been doing trainings every few years. You don't have to resubmit a fee every 2 years or what have you, like you do with your other licenses. So that's kind of a nice option. The perinatal mental health community definitely is a great community to kind of be connected in. And so they have their own conferences and listservs and all that as well. So I definitely, we don't do enough training I mean, at all, it doesn't get discussed, especially dad stuff, doesn't get discussed in our training at the master's level or the doctorate level, unless you seek that out extra, which is unfortunate because this really impacts the entire family. It's not just this little, you know, cute little package of 6 months and that's it. It's much bigger than that and impacts so much more people in that system. So, yeah.
Well said. Other final questions or comments for the group? Okay. Well, I guess we'll leave it at that. Brenda, thanks again for such a wonderful presentation. Again, a really important topic. I think we got really great discussion, hearing from others what people have been trying to do in their clinics. So we appreciate you being here. So thanks again. And for everyone, it looks like CHUSE is reminding you to vote for the election. So that will be coming up, and you should see that in the listserv soon, how to vote for co-chair and secretary. Thanks, everyone, and we'll see you in January. See you next year.
Thank you.
Bye.
Bye.